Well, thank you for that kind introduction. And I realize as I look at my title, To Treat or Not to Treat, this almost sounds like a debate. So maybe I'm going to be internally conflicted in debating myself because Brian was supposed to debate me but chickened out. I'm saying that because he doesn't have a microphone right now. So the natural course of post-operative Crohn's disease, you've probably seen this slide, and I think Steve set this nicely in his initial talk, and this really, I think, sets the basis for immune-mediated diseases in an interesting way. So imagine for a minute you have a patient who comes to see you who undergoes an ileocolonic resection. The disease, their Crohn's, for that split second, the surgeon leaves the operating room and there's no disease left behind. They're essentially surgically cured, if you want to use that word. But what happens over time? And we've seen this in multiple different studies. Within 1 week, if you were to take a biopsy of the neoterminal ileum, which by the way, I'm not recommending you do, but in studies that have taken biopsy from normal neoterminal ileum within 1 week, histologically, there are already evidence of Crohn's disease recurrence. Fast forward to a year, and we've seen this in our practices, and Paul Rutgertz in 1990 put together the pivotal study. If you do a colonoscopy on patients, up to 90% will have endoscopic recurrence. Now, it may be mild, but there's endoscopic recurrence. What happens over time, in about half of the patients, there's disease progression. If you do a cross-sectional imaging, they'll start to have changes in the bowel wall. They get symptoms, and then these patients come back to have surgery again. I think the part that's a bit frightening with all of this is what happens up top in the big blue arrow. Most of these patients are clinically silent, and this fits with what you see in your practices when you diagnose a newly diagnosed Crohn's patient. You do a colonoscopy, they say they've been having symptoms for 2 months, yet they have terrible disease, deep ulcerations, and you look at them and say, there's no way you've only had this for a short period of time. Same thing with post-op recurrence. The disease recurrence is clinically silent until it gets to a tipping point by which destruction occurs and they start to have symptoms. So imagine, if you will, two scenarios and think about what you would do in your practice with these two common scenarios. 22-year-old smoker, Crohn's disease for 5 years. The only prior treatment had been 5-ASA and 1 to 2 times a year steroids, now presents with a small bowel obstruction. So a scan is performed, there's a stricture in the terminal ileum, and there's proximal small bowel dilation. The patient undergoes a resection, 10 centimeters of TI is resected. There is a stricture in active disease. By the way, to have a pure stricture without any inflammation is extremely rare. So I think that nomenclature of fibrotic only is a little bit of a misnomer. But nonetheless, this is a 22-year-old who now has 1 surgery. What would you do? So aside from having them stop smoking, would you commit this patient to medical treatment or not? What about this patient? Maybe a different flavor. And one aspect of Crohn's disease, obviously, is things don't fit into just clear phenotypes, 1 or 2 diseases. There are probably 20 subsets of Crohn's. So this is a 43-year-old female with Crohn's ileitis, never been on medications. She is also a smoker in Pittsburgh. We have a lot of smokers. No NSAIDs, no family history. A CT scan is performed. So different than that stricturing Crohn's patient, this is a patient who has an abscess, so the yellow arrow, and the red circle is around a phlegmon, this big inflammatory mass in the terminal ileum. So obviously different than the first scenario. The abscess is drained. She ultimately goes to surgery. By the way, this comes up quite a bit. My feeling is if you have an internal fistula that leads to an abscess, I do not personally think that medical therapy works. We can have a debate about this, but if the abscess is drained, we're usually then timing surgery after this, but we can argue whether to start treatment. But in her case, her abscess is drained, she undergoes a resection, has a primary anastomosis, and now the question is, do you treat this patient? And if so, what do you use? So the main question is early treatment for most patients versus endoscopic guidance to guide your therapy. It was interesting to see that most of you picked, when Steve asked the ARS question, most of you picked that you would start early treatment. And I wonder if there's going to be flavors on who you start early treatment. It's probably not everybody, but for the high-risk patients, probably that would be appropriate. So what are the early treatment data? And this is a systematic review we put together almost 10 years ago, but it still applies today. When you consider clinical recurrence in the middle column, endoscopic recurrence on the right column, and you look at placebo, 5-ASA, the antibiotics, azathioprine, 6-MP, there are a couple of things that strike you, I think, on this. One, look at the nitramidazole antibiotics. So for those of you that use antibiotics after surgery, the clinical recurrence rate was quite low. So clearly the microbiome, the intestinal contents, plays a role. The problem is, and I challenge you in this room to come up with that microbiome altering agent that's well tolerated that alters Crohn's disease. Now you could argue that's probably diet, but in the United States having our patients change diet is nearly impossible. But it's interesting looking at the nitramidazole antibiotics at least early on. The problem is once you stop the antibiotic, the disease recurrence is high. The second is look at the placebo rates on this chart. Many of the treatments that we have pre-anti-TNFs didn't differ, even the azathioprine 6-MP didn't differ much to placebo. Well, what about the anti-TNF? In 2009 in Pittsburgh, we put together this small study of 24 patients, which half were randomized to infliximab after surgery, half were randomized to placebo. One key point when you read any post-op study is, what is the primary endpoint? The primary endpoint in this study was endoscopic recurrence at 1 year. So we wanted to know how it looked. We didn't care as much about their symptoms. Now, in this study, placebo in red, yellow is infliximab, we found a very large difference between the placebo versus infliximab rate, meaning that 85% of our patients treated with placebo had an endoscopic recurrence, which, by the way, was significant, meaning they had a score of 2, 3, or 4, not just a little bit of inflammation, and we can maybe, Scott, when we get into the discussion, not just a little bit of inflammation at the anastomosis, which we don't know what to do with these ring-like areas. These were patients who had significant disease. One caveat, this was a high-risk group of patients. Many of these patients had multiple surgeries. Most of these patients had penetrating disease. The problem is, and I would argue this myself, that in 2009, this is based on 24 patients. Brian would probably have another seizure if you were to tell me that in one practice of 24 patients, you're going to change everything. So one of my patients actually came up with a cute analogy of a bus, that now, because I have published so much on these 24 patients, that he feels that I drive my patients around in this one bus. And for the last 7 years, I've been publishing off of these 24 patients. So for me, these are very coveted. The argument, though, is that this is not enough for us to make a single paradigm shift based on this one small study. So there have been several studies, and sorry the colors are a bit off on this, but the anti-TNF column in the middle versus control on the right. Those in red are infliximab, those in the lighter orange or yellow at the bottom are adalimumab. So you have two different anti-TNFs, across different continents, different patient populations. And the one take-home message to remember, and if I were playing the lottery way back when, would be that number of 21%. When you look at the anti-TNF post-op rate endoscopically, it's about 20 to 22%. That was found in the majority of the early studies, and this was clearly beneficial compared to the control group. And then we had the larger PREVENT study, which Brian, Steve, many others in the room were involved in, which is looking at a larger sample of patients over a longer duration of time. A key point to this was based on clinical recurrence. Well, you could say, Regueiro, you're an idiot. You've already showed us that patients don't have symptoms in the first year or two. Why are you picking a loser clinical recurrence endpoint? Well, some of this had to do with regulatory guidelines and the FDA and some of the things that they wanted to see in a post-op study. So this is different than the earlier studies that I talked to you about. This is based on clinical recurrence. So possibly no surprise to anybody, and you've seen these data already. Placebo in orange, and in kind of the blue color is infliximab. Based on the primary endpoint of clinical symptoms, of clinical recurrence, there are two things that I think strike you on this slide. One, that p-value of 0.05 was not met, although there was a trend towards lower clinical recurrence in the patients in infliximab, it wasn't statistically significant. What about the placebo clinical recurrence rate? It's very low. So if you do nothing to your patients after surgery, you don't look and you just follow them by symptoms, the majority of the patients will actually feel quite well. Clinical symptoms are a terrible endpoint, probably for most of Crohn's, but not a good endpoint in post-operative. So those of you on the ARS system that mentioned that infliximab prevented clinical recurrence at 1 to 2 years, actually it did not. Based on the PREVENT study, it did not show that. If you look at secondary recurrence of endoscopic recurrence or endoscopic remission, then you start to see a separation like we've seen in other studies. So a strong biologic signal, and the orange again is placebo, blue is infliximab. We actually see a great separation between infliximab and placebo. So endoscopic recurrence is prevented, but the clinical recurrence is not. Now, Steve mentioned it ended at 3 years. I would dare say if we follow these patients to 5 to 7 years, as we followed our 24 patients in Pittsburgh initially, you start to see separations because once their endoscopic disease becomes severe enough, no duh, if you don't treat them, they will get symptoms at some point. But early on, that was not. Okay, so that's the start treatment after surgery. What about waiting to treat? And this is a concept that I think has come up somewhat in several studies, but one specifically in the POKER study. So I think people often say PREVENT and POKER. These are the two studies in post-op Crohn's, at least in the last few years. Now, this was a complicated study, but just to simply put it this way, all the patients got metronidazole after surgery for 3 months. If they had a high risk for recurrence, they would receive azathioprine. If they were intolerant to azathioprine, they were put on adalimumab. However, that was not the aim of the study. The aim of the study was half the patients had a colonoscopy at 6 months. The other half of the patients only had a colonoscopy at 18 months. So the half of the patients who had a colonoscopy at 6 months, if you imagine you're an investigator in that study, you do a colonoscopy at 6 months, and you say, oh, there's endoscopic recurrence. I want to optimize treatment. If they're only on azathioprine, I'm going to upgrade to adalimumab. If they're already on adalimumab, I'm going to optimize their dose. That's the active arm. That's the 6 month you take a look and you change treatment based on what you see. If they're in remission, you leave them alone. The other group is, we don't want to know what it looks like at 6 months. We're not going to look. We're just going to follow them out to 18 months, do a colonoscopy, and then compare the two groups. So one group had a 6 month look and an 18-month look. The other group just had an 18-month look. And what was found was interesting. If you actually, I'll just focus you on the red bars. If you look at the active care group, in red, by the way, is recurrence. The active care group on the left-hand side, these are the patients who had a 6 month colonoscopy, adjusted their treatment, and then 18 months had a colonoscopy. About half of the patients had endoscopic recurrence. However, over 2/3 of the patients had an endoscopic recurrence just by looking at 18 months. I think there are two parts of this that I want to point out. One, clearly looking early and adjusting treatment makes a difference. And I think that we can all now say in the post-op study, 6 to 12 months doing a colonoscopy and adjusting treatment makes a difference. The other thing that's interesting, and maybe this is I always hate feeding into Brian's arguments. That just somehow doesn't feel right to me, but I will. You could argue that azathioprine is the high-risk agent that was used in this, and by using azathioprine, you still had nearly half of these patients who had an endoscopic recurrence. One thing I'm not showing you in Michael Kam's article, which was very well written, but if you look at the adalimumab treatment group, 21% had recurrence. So adalimumab made a more significant difference. So after surgery, we're starting to see that the anti-TNFs, at least biologically, make a difference. So you're all sitting here and you're wondering, well, if you're starting an anti-TNF, do I start it early before there's active disease, or do I wait for recurrence? And the main question, as you've heard from all the speakers this morning, is, and this is true of any Crohn's patient that you see early in the disease course, and I think post-op really brings this to bear. When is it too late? When is the tipping point by which the disease has progressed to the point that you cannot recover with a medical therapy? Is it an endoscopic recurrence? Certainly once they have radiographic findings, and unfortunately, once they have symptoms, I think that this is going to be too far gone. So I'm just going to end briefly, and some of this I may skip through, but if you want to know, the AGA came out with guidelines this year. So this is actually very topical in 2017. I can tell you that some of the insurance plans are now looking at guidelines, not just post-op, but guidelines in general to look at pathways for hospitals and following. So this, for better, for worse, whether you like guidelines or not, these can make a difference. I was part of the panel that put together the technical review that ultimately led to the guidelines. And we basically came up with 4 questions. One is routine early post-op treatment, pharmacologic prophylaxis, superior to endoscopic treatment, meaning do you treat here before there's disease, or do you wait for disease? That was the first question that we had. The second is, and this was based on a large analysis, the comparative effectiveness of all of these agents. Now, I will tell you there's been no a priori prospective study looking at comparative effective to this point. So we had to do a meta-analysis or a network analysis. And then the third is routine endoscopic monitoring at 6 to 12 months after surgery superior to no endoscopic monitoring. Now, that seems like a simple question, but at the time, in terms of guidelines, there wasn't anything written on this. So should we monitor? And the question is, should we monitor early? And then the final, in patients who are asymptomatic, who have disease recurrence, what's the best treatment to start? So these are the patients you scope at 6 months to a year. For whatever reason that are not on therapy, you see disease, then the question is, what's the best medicine? And no, Brian, it's not a 5-ASA, so I'll get that out of the way early. So these were the 4 questions that led to the AGA guidelines. So why are guidelines important? This is actually a quote, and this is more getting into medical homes, but this is getting into alternative payment models now. These guidelines are intended to reduce practice variation and promote high-value care. This was actually written by the AGA. This is actually now why insurance companies and payers are starting to implement these into our electronic systems to say, can we decrease variation in care and come up with some unified approach? And some of this is based on guidelines. So these are the bottom line. If you're to remember anything from the lecture, these are what the AGA has put forth as the bottom line guidelines. The first, early pharmacologic prophylaxis over endoscopy-guided pharmacologic therapy is superior. So starting a patient early on treatment, not waiting for endoscopic recurrence, is the approach. So basically treat here, not here. So treat right after surgery, don't wait. In patients who have surgically induced remission for Crohn's disease, the AGA suggests using anti-TNF therapy and or thiopurine over other agents. And an important third point, and I think this is important because when we look at mesalamine use after surgery, this is still one of the highest prescribed medicines after surgery. The AGA came out and made the statement, in patients with surgically induced Crohn's disease, the AGA suggests against the use of mesalamine or other 5-ASA therapies. Number 4, the AGA recommends post-op endoscopic monitoring, which I think most of us are doing, and most would argue it's 6 months is reasonable, but you can make the argument out to a year if you're also following things like CRP and calprotectin. In patients with asymptomatic endoscopic recurrence, so this is the patient you scope at a year, you find that they have active disease, the suggestion is to initiate or optimize anti-TNF or thiopurine treatment. And then the question is, after all that, what does this mean for your practices? Well, I think one important point, and the basic bottom line is these are risk factors. So if you're sitting there and you're looking at a patient, the low-risk patient maybe doesn't need treatment. Let me repeat that. Not all patients need post-operative treatment. And you may say, who are these patients? Well, this would be the patient over the age of 50, non-smoker, first surgery, who has a short segment stricture, and this is the only disease that they've had in their lifetime. That's a patient that I think most of us would accept as a low risk. Now, when we did these AGA technical reviews and we sat, we had no guidance on this. There's not a lot of good natural course guidance to come up with these numbers, but we put hypothetical risks of 20% risk for clinical recurrence, 30% risk for endoscopic recurrence. The high-risk patient, who should you start post-op treatment? And today I would say anti-TNF treatment is the patient who's younger, under 30, smoker. The number one, this is another key point to remember, the number one risk factor that we found across studies is if it's a patient who's had their second or further surgery, not just their first, their second or more surgery, that's a very high risk, and especially if they have fistulizing disease. So the risks are much higher in that patient. Well, after all of that, my final slide hasn't changed too much, and this is how I approach post-op Crohn's. I will make one caveat adjustment from what's in these slides. I break them down into low, moderate, and high risk. So the low-risk patients who are very low risk for post-op recurrence, these are the patients I don't start on treatment. These are usually the single strictures. However, if I don't start these patients on treatment, I do think a 6-month colonoscopy is in their best interest. If they have disease, though, before I scope any patient, I tell them what I'm going to do if I see disease. It's often not good to not have that discussion, because if somebody feels well and in 6 months I do a scope and they have a score of 3 with deep ulcers, this is a patient I'm going to want to start treatment. So I tell them that before I do the colonoscopy at 6 months. The moderate risk group, I go back and forth. These are patients where if they could tolerate metronidazole or ornidazole at 1 to 2 grams, you probably could use that and azathioprine. The only thing I'll tell you is that the ornidazole, metronidazole tolerance rates are so low that I'm finding that most of these patients won't take it. And I wonder actually if we just split into low and high risk patients. So this might be a patient that I would now go to an anti-TNF. I've more or less abandoned my antibiotics just because I have not seen patients who are able to tolerate that. And then the high risk patients I think are a bit easier. These are the patients with 2 or more surgeries, fistulizing disease. These are clearly the patients I start today on an anti-TNF post-op. Actually, this morning I'm reviewing a post-op vedolizumab study that was done retrospectively. We're also now just about to initiate in Pittsburgh an IAS looking at vedo versus placebo endoscopic recurrence at an early time point. So we'll see about vedolizumab and others. But with that, I'll end. Thank you very much for your attention, and I'm happy to answer any questions.